Very good morning, good afternoon, and good evening, all the viewers across the globe of the vertebral views of the Ortho TV show. Also, Happy Republic Day to all the Indians in living in India and across the globe. Also, in Australia, they're celebrating Australian Day too. So today we have a very special guest, Dr. Hamid Abbasi. There are only few people in the world or neurosurgeons or spine surgeons who don't know Dr. Abbasi. His contribution to the Spine Society and the Neuro Society is magnificent. He is pioneer in Kambian Society as well as the Kambian Approach and Kambian Surgeries. He is the CEO and founder of the Inspired Sign USA as well as the Kambian Society. Not taking much of his time, we'll hand over to Dr. Abbasi, and he'll be talking today on the Kambian approach for lumbar decompression and fusion surgery. All over to you, Dr. Abbasi. Thank you.
Well, thank you, and it's a great honor to be with you, and I'm happy to be able to contribute. Obviously, all my contribution is based on the work of lots of other surgeons who have paved the way for what we do. No matter what we do, we are standing on shoulders of giants, and that one of those giants is Dr. Parviz Kambin. Dr. Parviz Kambin was born in Iran, and but practiced most of his life in USA. And I had the privilege to talk to him about 9 months before his passing. And if I can share my screen, I like to just honor him in my talk today, because considering what he put together, this is a tremendous achievement in his time, what he could achieve with the very limited material and things he had. He told me in person, when I talked to him 9 months before his passing, that he was baffled by amount of the damage we have to do to get to the spine. At that time, the main approach to the spine was so-called PLIF, posterior lumbar interbody fusion, and some surgeons would do anterior approaches. As a matter of fact, even before we start having PLIF approach in 1950s here, I want to share this screen with you. We started performing PLIF surgeries in 1950s, and by the time Dr. Kambin was doing that, that was the main kind of surgery. But in 1930s, actually, some surgeon did anterior approaches. General surgeon who went through the belly, opened it up, got access to the anterior part of the spine, and then we could take the bad disc out and so on. But the result very, very impressive. What Dr. Kambin told me, that he was baffled that, contrary to urologists or other people, we have to do so much damage to get to the spine. He told me he took a rigid endoscope of one of his friends and just put in the retroperitoneal space, and he could visualize the nerve root and disc base. And based on that, he actually did some cadaveric tests and identified this, what we call today, Kambin triangle. He told me as well that he sort of used a hatch-patch of endoscopic instrument from his urologist friend to do work there, and then practically solidified his work in the paper he put out there and anatomically described this so-called, what we call today, Kambin triangle. Now, unfortunately, in 1980s, we sort of neglected this beautiful approach, this beautiful corridor that nature has given to us. With we, I mean doctors here in the United States, because our Korean, Japanese, Chinese, and later on our Indian colleagues, they took it to the next step. And that is why endoscopy is so much more pronounced in the Asia than it is in the United States. And like electric car that it was invented in the United States, had to go to Asia and come back, the Kambin triangle and Kambin approaches had to go all the way to Asia, and you guys took on it refined it, and thank you, you gave it back to us. Now, Kambin and endoscopy approach is a big name here in the United States, but there's no question about that. Asian doctors, especially India, Korean, Japanese, and Chinese surgeons are much farther than we are. And I've had the privilege just to be in India shortly. Every person I met there is a master of endoscopy, and we have to catch up now on that. Now, the way I started doing the transcabin approaches has all have to do with my actual medical practice. I started my med school back in Iran in 1987, 86. The first year after Cultural Revolution, the universities were open. And I got in a little bit of a trouble, and they actually throw me out of the university. It was a very politically demanding time and tumultuous time. I went to Germany. I did a MD and PhD, and I don't regret that I did my PhD in computer science, which has helped me a lot since then. I did 3 years of neurosurgery residency in Heidelberg and Aachen in Germany, but then I went to Stanford. I was involved because of my PhD in creating a neuronavigation machine for spine. And obviously, they are big name right now. But at that time, we had to do really basic work, how we can use X-rays, CAT scan, register it in the spine. Now, in the cranial area, we are all familiar with it, and it has been working very good because the skull is fixed, but the spine is segmental, and it can move from the time you get the CAT scan to the OR, it can move. So we worked on that to make it possible. And that really raised my interest in the spine more and more, how complex spine can be. As a matter of fact, as every surgeon every neurosurgeon, I can tell you that the learning curve for spine is much bigger, much more pronounced than learning curve for cranial surgery. Like after 10, 20 brain tumors, you are good with your learning curve for tumor surgery in the brain. But after 2,000 surgeries as of now, after 4,000 spine surgeries, I'm still learning. Now, my exposure to the transcabin approach was when in 2011, 2012, I heard about the method of surgery that after spinal fusion, patient can be discharged same day. Until then, that was unknown to me. I couldn't believe that you can do that. I was at that time performing obviously PLIF, posterior lumbar interbody fusion, TLIF, transforaminal lumbar interbody fusion. I would say a mix of 20% PLIF, 60% TLIF, and then I was as well performing lots of A-lifts and X-lifts. But when I moved to a new hospital, I couldn't take my access surgeon with me for A-lift and X-lift. And at that point, my new access surgeon, and this is unfortunately not exaggeration, needed 3.5 hours to give me exposure for A-lift. Whereas in my previous place, my access surgeon would give me approach, give me my part to do within 20 minutes after start of the surgery. So now, not only that 3.5 hours to get exposure was not sustainable on the, that I could do only 2 cases a day, but as well, when you need 3.5 hours to get exposure, that means your complication profile is much different than if you need 20-minute approach there. So I was looking for a new method, and my blessing was that I'm a curious person. And when somebody told me they know of a new method in 2012 that was very new, and they know this patient go home same day, I didn't just dismiss it. I didn't just say, I don't believe that. I said, I don't believe that, but I want to see it. And I'm so happy I did that. I traveled to Atlanta, Georgia, and I watched my good friend, Dr. William Talley, one of the pioneers that started this transcambin fusion. And I watched him not only doing the L5S1 fusion under 1 hour, but I watched the patient literally being discharged a few hours later. Later on, when I talked to Dr. Kambin about what we are doing, he was amazed that how far further we could take the trans-Kambian approach, because his methods were solely on endoscopic decompression. He himself told me that he never believed that the fusion that our instrumentation or our technology can come so far that we can perform a fusion. And yet, in 2012, I watched that for the first time, that procedure being performed, and I was amazed of the skills of Dr. Talley, but it was clear to me that surgery, the way it was in 2012, which was just 2 years after this was started, can be done only in the extraordinary hands. Now, lo and behold, 12 years later, I'm proud to report to you, whereas in 2011, 2012, doing trans-Kambian fusion was like flying a space shuttle, only very experienced, very skilled people could do that. In 2025, doing trans-Kambian fusion is like flying an airplane. You still need to learn it, but it's not reserved for extraordinary skilled people. As a matter of fact, there's something that I talk to everybody that I train, and I have trained a lots of people, is that if you come and observe me doing a surgery, doing a 2-level fusion under 1 hour and send the patient home 2 hours later, if you come and see that and your takeout of that is that Abbasi is a skilled surgeon, I have failed to tell you my message. And my message is that an average spine surgeon with 20 caseload can perform this surgery safely, efficiently, and that learning curve is practically 10 to 20 cases. Now, I hate to report to you, after our residency, the way we learn new things is we go to Las Vegas, we are 4 hours in a lab, and then go have fun 12 hours, and then come back home and we try to replicate what we learn in the lab. This does not work like that. It is different enough that it has to be learned in a structured, protected way. And what I'm proud of is that whereas it took me 180 cases to fall below 1 hour, people who go through this structured learning, they fall under 1 hour after 12 to 15 cases. So I'm proud of that I could package the learning curve, that people add to my learning curve and don't have to repeat that. Now, we are going to talk a little about OLIF as a procedure, and why is it that we have to add it to our learning curve, we have to add it to our toolkit as a spine surgeon. And another thing that I tell to everybody is, this is yet just another toolkit in your toolkit. It is not supposed to replace all the other methods you have. But in 2025, if this is not part of your toolkit, you are not a complete spine surgeon. Now, as I was telling that in 1950s, we start doing PLIF, and then people quit doing ALIF actually. ALIF has a return in 1970s and 1980s after our abdominal surgery became so refined. In 1970s and 80s, Dr. Harm in Germany, by the way, he's closing to 90 years old, and Heidelberg is where I did my med school, so he's still practicing limited practice there. He started popularizing that taking the facet off and going transforaminal. Guess what? That was investigational, and it was a huge reservation from spine community to do that. And it took him literally 10, 12 years before people start taking it as a standard of care. And obviously, in 1990s and in 2000, lateral approaches become really popular. The real lateral approaches, the number seems to be going down in the United States. And there is a new resurgent, what we call prone laterals, that people go truly prone lateral, meaning patients prone, and they go transpsoas. It's an awkward positioning. Few people have taken on that. It's very fashionable now, but obviously, we have to see. And there is another approach that is as well called oblique lateral interbody fusion anterior to psoas, that this is practically a modification of ALIF from the more lateral approach. And I'm going to tell you what attracted me to OLIF, to oblique lateral posterior lumbar interbody fusion, where patient is prone, and all the approach is practically in prone position. Whereas in ALIF is a fantastic surgery for L4-5, L5-S1. OLIF ATP is actually more difficult approach for L5-S1. So for
Thank you, Poonam ma'am, for taking care of that. I think the scammers.
Sir, you are muted.
Dr. Abbasi, your voice is muted.
So, okay, I think we got hijacked by scammer.
Yeah.
So whereas ALIF is a fantastic surgery for L5-S1, OLIF ATP is a very good surgery for the rest of the vertebral bodies, but it's very awkward for 5-S1. As a matter of fact, the L5-S1 OLIF ATP is a procedure by itself. XLIF is obviously not a surgery that can be done in L5-S1. Very difficult, complicated ridden surgery for L4-5. But it's a very good surgery from T12 to L4. What attracted me to OLIF is that it can be done from all the way from T10 to S1. And the reason it can be done from T12 to S1 is obviously the learning curve as well is important, is because that distinct anatomical approach is preserved, well-defined in all those levels. And because we are not traversing psoas muscle, it gives us a good understanding about approaches. Now, we have published now, we have 13 papers now published about that. And my number as of yesterday is 1,709 patients that I have done over 3,000 levels. So what I'm presenting to you is not based on a handful of cases, it's based on a tremendous number of cases. And I think this summarizes what the impact it has made in my practice. As a matter of fact, even those complex cases, 95% of my surgeries are under 2 hours. Why is it important? See, if you look at the numbers, statistical numbers, economical numbers, spine is growing. In the number of the cases we are doing is growing in the United States. And I looked at it now internationally as well. That number internationally as well is growing because population is getting older everywhere. And problem with the spine is a problem of the aging spine. Based on Becker Spine is a web page that lots of spine are published there. Based on Becker Spine, 1.6 million instrumented spine surgeries are performed in the United States annually. Why is it important? It is important because we cannot accommodate all these patients. Our medical healthcare system will break down if we continue going this route of patient get a spine surgery, stay in the hospital a week, all the complication rate, all the resources we have to spend. In other fields, like, in abdominal surgeries, in gynecology and so on, how they could overcome those problems is actually transitioning those surgeries from a hospital to a surgery center to day surgery. And guess what? One of the requirements to be able to do a surgery as a day surgery is how long do you put the patient under anesthesia? So the time under anesthesia is an independent factor of the surgery. Please go ahead, Raj.
No. Continue, Dr. Abbasi.
So, and this is a study that we published. And obviously, This is about 400 cases in one hospital, entire, all the fusions. The blue line is literally the regular TLIF that should be considered by number the most performed surgery for fusion in the spine. And as you see, when the BMI goes up, the time on the anesthesia goes up. And these are very well-versed and experienced surgeons. And as you see, the time on the anesthesia goes up, and we have correlated that with all the other complications associated with the surgery. Now, MIS TLIF is a huge, I would say, a procedure that is getting promoted in the United States and globally, and is a very powerful surgery. And the red line, what you see here, is the performance of the MIS TLIF in the hand of somebody who is a star, extremely experienced MIS TLIF surgeon. As you see, at BMI of 37, the profile of the open surgery is better than MIS TLIF, and it makes sense. At that BMI, you have to work on a deeper hole, and the risk profile is very different. Now, the green line is actually the trans-Kambin OLIF, that it literally, you have the same profile in a BMI of 25 and 45. And the second study actually confirmed that that as well can be performed with the same profile in higher BMI. We have done, meanwhile, surgeries on BMI up to 62 or 64 even. And I just want to show you this, this is a patient, and what we need obviously always to understand, we are helping patient. They are not numbers. They have their individual stories. And I want to tell you the story of this patient who actually want me to tell the story because he had a laminectomy, and he had a 4-level spondylolisthesis, and he has been told rightfully by lots of surgeons, there's no way we can help you. You will die if we do surgery, 4-level fusion for you. If you do that surgery, it's an 8, 9, 10-hour surgery, and your lung will not recover from that. And he was miserable. He couldn't walk for 6 months. And now, when patient or people, when they cannot walk, they recondition. As a matter of fact, there's a good amount of data. We spine surgeons, we always say surgery is not safe. We cannot do it for you. We are not reducing patients' risk. We are just pushing the risk somewhere else because we looked into the data. This patient, when they quit walking, within 6 to 12 months, they die of cardiovascular. The lung condition goes down. When they quit walking, they die of cardiovascular complication. We didn't reduce the risk to them. We just pushed the risk from spine practice to cardiovascular practice. Now, this is another patient, was only half an hour on the belly. You see how the area that he's laying on is discolored. But look at this patient. This patient was 52 minutes prone. And this patient BMI is just 53. But you see how cyanotic he is in the upper extremity. So this patient do not tolerate to be prone for too long. Now, this patient, if you put him 8 hours prone, your risk profile is not just spine risk profile. The brain, cardiovascular, and so on and so forth. They have a huge risk profile. And what I'm getting at is that every additional half an hour on the anesthesia adds 17% to the combined risk of the surgery, and we need to be aware of that. One of the biggest advice I can give to you, any young surgeon, is that no matter what method you're using, especially in elderly or high BMI patient, use the method that the total surgical time is less than 3 hours, because after that, the risk profile is not linear, is exponential. Now, I just want to tell you to this patient that we just watched here, the way we do this surgery is obviously, number one, I use 2 C-arm. That really helps you to reduce the time of the surgery because you don't have to go with the C-arm back and forth. You have to optimize the tissue distribution. There are methods beyond this conversation, but there are methods to optimize your x-rays. And all of that, we look at that just by using some tape. We go from this picture to this picture. So this method can be learned. You don't have to reinvent that. You just have to go to my album on neurosurgery case review, and it's called facebook.com NS review. And then you get all this information, how to can use this method to optimize. And then obviously, what I think is important is that we use a tube system. Now, what is the advantage of a tube system? The advantage of a tube system is that it doesn't matter if you go through 4-inch of fat or 8-inch of fat. At the end, you perform, as long as you get a good picture, you perform the same way. Now, let's come back, and I think what's important with transcambin olive, you don't need a tremendous number of instruments to perform the surgery. There's a limited number of the material what you need to make the surgery happen. And I'm proud to say our Indian colleague are going to have those sets, which is practically a dozen of instruments very soon. We opened up our chest to them, so they are going to produce it. So it will be available to the rest of the world at the affordable pricing. And here you see, like here, I have to push these screws. These are tower screws. I'm going to show you that how these screws are going to place. But coming back, that we are treating patient and not a number, not just a condition. These are patient. This is the mother of the same patient you saw before. She has tears in her eyes because after 6 months, for the first time, he sees his son walking again. And leg pain is gone, patient is walking. So by daring to go to a territory that is new, we are able to help patient that otherwise would not be a candidate for other surgeries. Now, I like to show you, instead of going through a bunch of slides that I have, and I can show it to you how the surgery is done. I like to show it to you actually on an X-ray. And I think that visualize the steps of the surgery, but it requires practically 2 C-arm and identifying the center and trajectory of the approach on 2 views live. One of the problems with navigation is you get a CAT scan, as soon as you get the CAT scan, your information is historical. You're just relying that nothing has moved. But once you start hammering, once you start putting the first screw, your data is historical. I did program those machines. I can tell you that when you get it, like you put a DRF, dynamic referencing frame, on the iliac crest, and then you start using neuronavigation, every segment at 13 to 15% error to your registration. Like you put a iliac crest DRF, from iliac crest, which is sacrum, to sacrum, it's 1 segment. Sacrum to L5, second segment. L5 to L4, third segment. Each segment at 13 to 15% to your registration error. That's physics. You cannot change that. But then you start hammering and changing the anatomy, then your registration is almost gone. So it's not unusual to spin the O-arm and so on 3-4 times in a big surgery, and now add all those times to that. Now, with the double C-arm, you have actual live view right there. And then it's about instrumentation. That is all about instrumentation. And this instrumentation, once you get used to it, they perform in any hand very effectively. And now I like to just show you 1 X-rays of such procedure. So this is a isthmic spondylolisthesis, and we are going to do first to draw those lines. What you see here is the K-wire, and I'm drawing that line under skin of the patient and identify my landmark. Now, once I have done that, I go with what we call the Jamshidi needle. I take bone marrow from one of the levels, and then I mix it with my biologic. This is a neuromonitoring probe. I'm going to go back here. So once I have my drawing, I go at an angle that take me at 45 degree, and I always try to hit the pedicle of the level below. Then I drop in. The nerve root is closer to the pedicle of the level above. I stimulate constantly at 3 milliamp. And now there is multiple ways, obviously, get a Kambian approach. My very good friend, Dr. Varun Agrawal, using neuromonitoring by keeping the patient awake. Patient can tell you how close you are to the nerve root. And my other good friend, Dr. Vasavada, is using other technique called KLF, or what we call Kambin lumbar interbody fusion, where it's defined in the United States as fully endoscopic. You put the endoscope there, you identify the nerve root, and then you're sure that you're not going through it. I use a neuromonitoring where we put needles in the legs, in certain muscle like vastus lateralis, hamstring, tibialis anterior, and so on and so forth. And we are literally putting 3 milliamp on tip of this probe. This probe is insulated all the way to the tip with Teflon, and the signal only gets transmitted through the front of it. Now, if you are at 3 milliamp and none of those muscles in the leg are shooting signal, and this signal is beyond what you can see, it's not like leg jumps up. But that is the beauty of this neuromonitoring, is that even very light signal get recorded. So our study show if at 3 milliamp you don't get any signal, you're about 3 to 4 millimeter away. At that point, I go to 4 milliamp, and at that point, you're securely 5 to 6 millimeter away from the nerve root. Now, and the idea is here is that once I am there, I put a K-wire, as you see here, then over the K-wire, I dilate it. When I dilate it, it actually pushes the vertebral body up, and that helps us to push the nerve root. Even in this situation, the nerve root is here, and I'm still having my free run EMG, okay? So once I have dilated, I put a tube in. The tube is 8 millimeter inside, 10 millimeter outside, and that is what the magic starts, where we use a certain amount of tools, very specialized tools, to do the discectomy, to do the preparation of the end plates, and then literally over a K-wire put the cage in. Now, what I need you to know is what doesn't come out from this moment when I start the surgery to this moment when the cage is placed is literally taking me 8 to 10 minutes. And because I don't have to do the typical action of a surgeon, cutting the muscle, cutting the skin, stop the bleeding, coagulating the tissue, approaching more and more and repeating that process. It's that this tube system is what really makes us very efficient to go there. And another thing I wanted to look at is look at this so-called foraminal space here and compare it to before. I think if you measure that, you see that this space is at least 2.5 times bigger. And the way it works is that, you know, if you remember, it works with the square R. If you add, like, if you double radius of a circle, you're not doubling the area, you're quadrupling the area. In our study, we found out that if we increase 2.5 to 3 millimeter in the average person interdiscal space and interpedicular space, we are doubling the area space of the lateral recess foramen. And for most practical purpose, that suffices to remove the symptom of foraminal and lateral recess stenosis. Now, having said that, again, the indication for the surgery is a different topic, which we discussed previously. So, but practically at this point, 8 minutes to surgery, the cage is placed. And now what we are going to do, we are going to, obviously with a minimal invasive technique, which is well defined and refined, and our colleagues in India are fantastically good at it. We put K-wires, we literally put a pedicle screw, and then instrument posteriorly. Now, I hope you understand the difference between instrumentation and fusion. Instrumentation is putting the screws in, whereas fusion is adding biologic to make the bone as well in the facet or in the back grow. Now, this is another device that we use, is that over the K-wire, it goes in, it's eccentric, it goes through the K-wire that is going to the pedicle, it centers on the facet, and it grinds the surface of the facet, literally enable you to fuse as well that segment, transfacet fusion, and then you achieve both interbody and posterolateral fusion. And you see now this device that literally grind the surface of the facet and achieve the posterolateral fusion for you. The rest is obviously nothing out of ordinary, as described by Dr. Foley and many others, to put pedicle screws and then passing a rod. Now, idea is here that what you do is you get good at doing it for one level. Once you are good at doing it for one level, you just repeat that. You repeat the process, okay? And what I want to everybody understand is that what you see in this picture is all you need to do the surgery. You don't need a $1 million O-arm and a $3 million robot and a $500,000 annual subscription to perform this surgery. You need a handful of tools and skills. And what I have learned in my travels around the world, there is abundance of skills in many of those countries that we consider developing countries, and that can be tapped on. Now, I want to just show you 2 more slides or 3 more slides and then be done with it. Now, obviously, the question is always, can I prepare the end plates? Can I take the disc out? Well, it's about instrumentation and tools, and I guarantee you, anything you can take with the regular methods out, you can do with these specialized tools. And I'm not going to go, actually, maybe it's not a bad idea to go through this video that visualize the concept of it. You see the nerve root, you see the ganglion, and the patient is prone. Obviously, I don't go back and forth. I use 2 Shyam because that makes me a lot more efficient. But once you identify the trajectory of the disc in AP and lateral, then especially in the lateral, you have to be able to see the crisp end plates. Then that enables you to triangulate to go at 45 degree. And all of these are skills that we teach in our labs. And then when we go at 45 degree, now here, this try to navigate it freehand to the Kambin triangle. I learned always to hit the pedicle of the level below and then slide it down. That alone has saved me a lot of the time. Here you see that insulated probe shoot the signal to the leg, and then you can collect it with the neuromonitoring. And once you redirect it, you're able to get a better approach without being in vicinity of the nerve root to get the proper approach. And then K-wire in, dilator in, over the dilator, the tube, the working cannula goes in. And then literally those special instruments come to play. And certainly it takes time to get used to this set of instruments, but it get used to any set of instrument, and the learning curve here is no different than any other learning curve. As a matter of fact, I would justifiably be able to say, because you have a smaller set of tools, the overall learning curve is here faster than if you do a regular PLIF or TLIF, where you have like 120 instruments on the table. Here, truly, it's just a handful of very specialized instruments that get the job done. Here you see how we are removing the content of the disc. And then another advantage of this, what I do is that I fill the space inside and outside of the cage with biologic. Now, why didn't I do it for my TLIF and PLIF? In my TLIF and PLIF, the entry to the disc is right where the nerve root is and the spinal cord is. So I was very hesitant if something backs up. But here, the entry is extraforaminal, So even if something backs up, it's in the retroperitoneal space, not in foramen or in the spinal canal. So I'm way more liberal to pack it. And I'm so happy I'm doing it. In many cases, I see the fusion actually outside of the cage with this method. Now, I don't use PEEK cage anymore. Like many of our colleagues, I have gone from PEEK cage to titanium cage, which is way more robust. Now, I want to actually go back here and tell you that few more things, that once you get good at it, then you can repeat the process and go from left picture to the right picture. And the fusion happens in higher rate, like any other muscle sparing technique. Fusion is way superior to the traditional because you're not stripping the muscle of the bone. You're not causing lots of damage to the surrounding tissue. You're not reducing the vascularization of the bone. And the end result is just few holes in the patient. And again, these are patient. And I'm going to close it with this. This is a patient who had some comorbidities. Two other surgeons told her she cannot have the surgery. It's not safe to do the surgery. They weren't bad surgeons. They were good surgeons. They estimated in their hand risk versus benefit for this patient, said she cannot have the surgery. Now, this patient couldn't just live with it. She couldn't walk to the kitchen to eat. She lost 40 pounds. By the time I met her, she was under about 100 pounds. And we know what dangers are there to do surgery on those group of people. She was miserable. The reason I could do this surgery is because I didn't need the whole day to do the surgery. My blood loss wouldn't be half a gallon to do this surgery. As a matter of fact, this is the actual patient 6 months after the surgery, and this surgery was done under 2 hours with 230 cc of blood loss. You see, the risk profile of a surgery that's 2 hours and 150 cc of blood loss is very different than a surgery that is 8 hours and 2000 cc of blood loss. All of a sudden, we can help patient that in no other way they can be helped. By the way, this is the patient. You should be able to, even hard for you to say which one is the patient. And she's not 100 pounds anymore. She has gained weight, and she's not. She's able to live again. Now, I'm going to stop here. There are lots of other videos in other medias about the actual process. My talk in the Seattle Science Forum is all online and so on, and we can share all of that with you. But I don't want to drag this further. I think the actual technique needs to be learned in a closed, in a very controlled environment. And we have created that. We call that soft transition, which comes in 7 levels. One of the reasons this hasn't caught attention is because I did a study. I went out and did a survey of the people who learned that. The company that introduced that, used to be called Amendia. They actually trained about 450 people, 450 surgeons. And I did a survey. Vast majority of them gave up after 5 to 7 cases, where they literally found out that the results, the nerve root injury is up to 70%, 80%. Then they gave up on that because they learned it in a course in 4 hours, then went home and tried to do that. That is just not good enough for this. Now, our soft transition is in 7 levels. The level 1 is, it starts with the cadaver course. Actually, it starts with the pig lab. Second lab is a cadaver lab. Then we gather cases, we do cases together in a control environment, L1 to L5. Then the level 2 is L5S1, level 3 is spondylolisthesis, and we go various levels and the degrees of scoliosis and spondylolisthesis. But that learning curve, I can just tell you, is number 1, no different than learning curve for any other procedure. And you don't need to have, like me, 500 cases before you do scoliosis. My good friend, Dr. Gasco, is a master of grade 2 spondylolisthesis. He started doing these kind of very difficult cases including grade 2, 3 spondylolisthesis and scoliosis after just 70 to 100 cases, whereas I started doing them after 500 to 800 cases. So this is a learnable skills, and lots of people are getting on bandwagon now, especially lots of our Indian colleagues are getting on that. So I'm going to now quit here and maybe ask, answer some question. I know there are lots of questions probably out there. There's a lots of legitimate, let me be very clear. There's a lot of legitimate concerns here. Rate of nerve root irritation, instrumentation, fusion rate, lordosis, and so on and so forth. But let me tell you two things from the history, which we as medical community, we have to come clean with. A good medical new technology in average takes 15 to 28 years to establish itself. Because there's good way that we deal with that. We want to have evidence that what we are doing is working, it's helping the patient. But sometimes that get bastardized, that get hijacked by people who are just trying to keep the status quo, financial reason, and so on and so forth. Now, let me tell you that after 1,709 cases, I have the clinical evidence. Many of my colleagues have that. It is not a solution for all problems, but it is a good way of treating many patients that otherwise don't have any viable other options. You have to come in medicine clean that there is remember Ignaz Semmelweis. For those of you who don't know who Ignaz Semmelweis was, is that his statue is in Vienna in front of a hospital. And it breaks my heart every single time I have to tell the story, because he discovered there were two birthing places in Vienna. One was run by midwife. One was run by midwives. One was run by doctors. Now, what was the difference? The doctors would go to the cadaver lab, and then after cadaver lab, they would go to the birthing place and give birth. The women who were admitted to the doctor's ward, they had 10 times, actually 12 times more mortality than the women who were admitted to the nurses or midwives, nuns ward. The whole Vienna knew that. This was not a mystery. This was not a secret. It is said that women, and the way it was handled is that one day women were admitted to the doctor's ward, and the other day they were admitted to doctor's ward, nun's ward and doctor's ward, one day after another. At midnight, the time would change. It is said the women would cry and beg to be admitted to nun's ward and not to go to doctor's ward, because everybody know if you go there, you'll die of purpura, of fever, of this infection, because these doctors would go because these doctors would literally go to cadaver lab and drag all those bacteria and come infect the woman, and those women would die. And at the rate of 30% of the women would die. Women would stay in the front of the hospital, give birth in the front of the hospital, rather than to be admitted to the hospital. And do you know what this, when Semmelweis went to the establishment and said, wash your hand with this stuff, do you know what the establishment told him? You are crazy. You think a gentleman's hand can transfer disease? Did not have social media. What he did, he would go and distribute pamphlet on the street in Vienna to the women that go require their doctors to wash their hands. Semmelweis' chef or boss told him, Ignaz, I don't need new ideas. I just need people who follow our tradition. With other words, shut up and do what everybody else does. Do you know how many women died in that process? You go look it up. So remember Ignaz Semmelweis. He wasn't accepted in his time because at that time, there was no social media like what you are doing, Raj. There was no podcast for
Yes.
people to say you don't have to die of spine surgery. He died in a mental asylum because he was ostracized. Remember Ignaz Semmelweis. Now, I'm going to tell you something. The rate of dying of spinal fusion, lumbar spinal fusion, complex spinal fusion in the United States is 0.2. In some statistics, it's 0.2. In other statistics, it's 0.3. Meaning from 300 people, one person dies of spine surgery. This is a marvel of medicine that so few people die of that. But you translate it to 1.6 million spinal fusion performed in the United States, then you're talking about the entire people on 20 Airbus or Boeing. So every year, 20 Airbus people crash and die in the United States. And guess what is the my mortality of my transcamin Olaf? 0. After 1,709 cases, there are many cases, and I take care of most complex cases. They come to me from the United States. So coming back to that, we should be always careful. We should look at evidence. We should literally look at all the surrounding of a new procedure. But in 2025, you have no choice but to add transcambin approaches to your toolkit. So I'm going to stop here. This has been a little more than 45 minutes, but I'm going to let you ask some questions.
First of all, a very inspiring and inspiring work by Inspired Spine, a very philanthropic approach you have, Professor Abbasi, making people learn and developing technology so that it can be distributed across the globe and can be followed. We are OrthoTV and across the people. We very much thank you for your time and sharing your knowledge. Also, if we could have time to just ask one question, like we have gone through YouTube, your 2 cm technique, which is very useful. If for the benefit of the audience, if you could just demonstrate or show clip of this 2 cm technique to save the time during the theaters.
Absolutely. So I have obviously, multiple different, and I invite you, let me share my screen one more time. I have multiple venues to spread the knowledge. And I think that's really what I'm proud of, that with what I have done, you don't have to make your own learning curve. You can add to mine. And one of that is what we call my own blog on Facebook. It's called Abbasi NSGY. And the other one is a NS review. And there are 400 patients on NS review, that different patient, different approaches, not just all of it, it's anything else. But on if you go to my album, and then you just come down, and then one of the album is called Setup. And it literally talks about the entire step and the setup of the C-arm. I tried, I would say probably a dozen different setup in the war. The problem is with 2 C-arm, the space become really, really small for you to work. Now, we came up with 2 different C-arm setup. This setup, we called it the Crookston setup because I'm doing it in a hospital in Crookston. This applies if you have a machine that have 4 degrees of freedom. Now the C-arm, they come in different variation, but more or less, they have either 4 or 5 degrees of freedom. If you have machines that have 4 degrees of freedom, this is a simple approach, simple setup, works in 80% of the cases, where the lateral machine actually goes over the patient. The AP machine comes at an angle and the surgeon is on the other side. And in this approach, obviously, patient is prone and surgeon stands next to the receiver on the other side. And there is another approach. This is what we call Alexandria approach, because I performed that mostly in Alexandria, another hospital. That requires a kind of C-arm that they have this what we call Super J, a 5th degree of freedom. There are videos of that. There are actually setup of the room in my blog. So feel free, go download it. If you cannot find it, contact me. I will send you the entire setup, which each device, each machine in the OR need to be to optimize your approach. Now, what's the problem? If you don't set it right, you cannot maneuver these two machines around each other, and then you get a suboptimal picture. And that is literally the worst thing can happen in this surgery. You need to have good pictures because that is where your eyes are. And this two C-arm setup, this is again so-called, you see again here the approaches and so on, and there are videos as well how to do that. Now here you see the so-called Alexandria setup, where the lateral machine comes at 25 degrees to the bed, and you use that what we call the Super J. You see that go there, it goes over the patient. That is extremely helpful for scoliosis because, believe it or not, I do scoliosis of 60 degree and torsion. It's even worse, to compensate for that, of 40 degree. Sometimes for me to get the true AP and lateral of the patient, my AP has to be at this angle to get the true AP of the patient, and so on and so forth. But once you have the good picture, you just pay attention to the picture and it guides you where you need to go. All those informations are available on my blogs. One is Abbasi NSGY on Facebook. The other one is NS Review. And these blogs have been there for 14 years. We have over 30,000 followers on those blogs and so on. Feel free to join us. And if you don't find the specific setup you're looking for, we will send it to you.
Thank you, Dr. Abbasi. It's really helpful for all the surgeons across the globe. The work you're doing is phenomenal, and everyone appreciates your work. Do we have one more question? Time? Okay.
Absolutely. My time is yours.
Yes. So currently, like we discussed this before multiple times, the amount of lordosis we can achieve with the Kambian approach. As new literature suggests, we should have good amount of lordosis at L4-5, L5S1, the Rosoli classification, the new L1 hip axis. They demonstrate achieving more and more sagittal correction. Definitely, we achieve good coronal correction with the Kambian approach, but if we want to achieve more lordosis and global spinal alignment, what do you suggest, Dr. Abbasi?
Well, as we discussed as well in the indication podcast yesterday, is that you have to have other tools in your toolkit. This is not your only toolkit. Now, our study that is already published in 2017, 2018 shows that we can correct 5 to 7 degrees in the coronal plane by putting the cage right, left. And just yesterday, I did that surgery on a patient with a 35 degree scoliosis, which was completely corrected, but generally that's too much. So most of the time you can correct 5 to 7 degrees per level in the pre-op CT to post-op CT. Now, obviously, if the pre-op CT is 35 degree and patient stands up, that's not 35 degree anymore. It's 45, 50 degree. But then post-op, you can correct it down to 12 degree, which is quite tremendous. And most of the time is enough. If that is enough for you, that is the way to go. Now, regarding the sagittal deformities, I have not published the data. It will be published. We can correct 2 to 3 degrees per level by literally putting this cage horizontally in the apophyseal ring in the front. But that is, it requires often not the trans-Kambin approach, same instrumentation, same setup, same process, but the trans-psoas approach.
Mhm.
And we have published that. If you just now go Google Abbasi, NIH for National Institute of Health, MIS DLIF, that is our prone lateral version that enable you to go truly horizontal, trans-psoas, and literally put the cage in the front of the disc and lift it up. And that help you to, in average, hopefully that this will be published this year, we can correct 2 to 3 degree of lordosis. Now, if that's not enough for you, remember, there are other methods like ALIF, like XLIF, like sometimes you have to do facetectomy to achieve more kind of thing, but you have to weigh that. On an 88-year-old person, do you want to do a ped osteotomy, or
No.
do you want to do a, well, no, sometimes that might be the answer. Sometimes that might be the answer, but, or do you want to do something that is more efficient, less blood loss, and so on? Now, if truly correction of the, now let's put it this way, ALIF is a beautiful surgery, and if you have the right access surgeon, it can do a 1-level ALIF in under 1 hour. But then, are you going to posteriorly instrument it? Then you are adding another 2 hours to it, and so on and so forth. So you have to weigh and balance risk versus benefit for each patient individually. But based on my data, you can correct 5 to 7 realistically very easily in the coronal, and about 2 to 3 degree in the sagittal plane.
Thank you very much, Dr. Abbasi. We have guest, Dr. Salami. Do you have any questions? Anyone in the audience, do they have any questions? I think that's it for today, Dr. Abbasi. We really appreciate time from OrthoTV, our mentors, Dr. Ashok, Shyam, Dr. Neeraj, Bijlani, and Ms. Poonam ma'am from OrthoTV. We all thank you for your time, and it was a fantastic talk. We really had a good time. Hope to see you in future.
Well, it has been my pleasure and my honor to be with you. Thank you for your good job. One of the things that we as surgeons have to do, educate. Not only our colleagues, but as well the patient as a bigger team. And I have been following you, and I'm very happy for what, and I'm really honored to be on your show. And thank you for the good job you do.
Thank you so much, Dr. Abbas. It's all
Thank
of
you.
the TV and mentorship.
Okay.
Thank you, Dr.
Bye-bye.
Abbas. Have a good day. Bye-bye. We can go offline, Poonam ma'am, now.